Good afternoon. My name is Aisha Usman. I work at Mental Health Foundation Australia and your host for today's Child and Adolescent Mental Health Forum. We begin by acknowledging the traditional custodians of the land on which we meet today. I would like to pay my respect to elders past and present, and I extend this respect to any Aboriginal or Torres Strait Islander people joining us today. On behalf of the Mental Health Foundation Australia, I would like to welcome and thank each and every one of you for attending today's forum during the National Mental Health Month. This is an initiative of the Mental Health Foundation Australia to advocate and raise awareness of Australian mental health as a community. The National Mental Health Month is unlike many other mental health awareness campaigns. It aims to bring all Australians together in a nationwide conversation about mental health, and we aim to maintain this conversation for an entire month and beyond through a series of various mental health related events. This is a program that the Mental Health Foundation Australia is extremely proud of, and they intend to reach out and educate as many Australians as possible to help reduce stigma and facilitate positive and non-judgmental discussion surrounding the important topic of mental health in Australia. Throughout this month, many events have been organized in each state and territory of Australia, covering mental health discussions from over 20 different community groups. This year, the theme of National Multicultural Mental Health Month is Celebrating Diversity, Healing Together. This year's theme will focus on raising much needed awareness of mental health in culturally and linguistically diverse communities. With this theme in mind, we aim to extend our campaign even wider than previous years, with events planned to embrace many different community groups and people of all ages to talk about mental health together. Please join us in celebrating Mental Health Foundation Australia by viewing a short video.
Welcome, I'm Peter Barlas, Chairperson of the Mental Health Foundation Australia. Now, as an organisation, we are the oldest community-based and non-government mental health organisation in the country, with a rich legacy of dedicated service in our community since 1930s. I want to take you through a little about our programs.
Hi, I'm Vasan Srinivasan, the CEO of the Mental Health Foundation Australia. In our mission to promote mental health and well-being, we understand the power of community. Let's meet the human pillars of a foundation, the one who amplifies the community's voice in promoting mental health and well-being. Our network of community and media partners, multicultural attachés, and youth leaders and volunteers play a vital role in our journey. The unwavering support and dedication inspires us to reach even greater heights. Through our multicultural network, we have been able to create impactful educational and multicultural webinars. These webinars provide valuable insights on a range of mental health topics and practical coping strategies. Our community stories and experiences fuel our efforts to make a positive impact on mental health. We extend our deepest gratitude to each one of them by helping us make a difference. This year, we hosted our annual Multicultural Gala Dinner in July to celebrate diversity and spotlight the various rich cultures that make up our communities. Through this event, we jump-started the journey of our Multicultural Mental Health Month in October.
In a world where mental health matters, the Mental Health Foundation Australia has been leading the way. Since the 1930s, the Foundation has been dedicated to promoting better mental health for all. It has been an incredible journey for the MHFA as it grows stronger and more impactful each year. This year, we introduced new talents through the internship program, providing university students with an extraordinary opportunity to make a difference. Through the program, these young and aspiring individuals have been given the chance to work on key projects, making a meaningful impact in our organisation. Even in the face of adversity, nothing could stop us from raising awareness and advocating for better mental health. When COVID challenged us, we successfully adapted, shifting our events to virtual platforms to make information accessible to everyone. This October, we embark on an expanded mission to educate and support multicultural communities with the theme of celebrating diversity, healing together. Our aim is to reach out to as many Australians as possible, reducing stigma and fostering non-judgmental dialogue. Reaching many people around Australia requires help from our incredible supporters and dedicated volunteers. We want to take this opportunity to thank each and every one of you for making a difference. We hope you will join us on this journey to promote better mental health for all.
Last year, we launched our first ever integrated wellness hub, dedicated to providing inclusive, affordable and accessible counselling services to those in need. We opened our doors to people who typically cannot afford traditional psychological services. We believe that everyone deserves support regardless of their financial circumstances or their cultural environment. But what sets our Wellness Hub apart is the innovative Wellness Wheel concept. We've established relationships with multiple service providers ranging from allied health workers, community organisations, housing associations and job agencies to law firms. This allows our clients to receive comprehensive care tailored to their individual needs. It fills us with great pride to announce that over 500 clients have found support through our Wellness Hub so far. And this is just the beginning. We are committed to expanding our reach and helping even more individuals on their journey to mental health and well-being and building their resilience. If you need someone to talk to, the Wellness Hub is just one call away.
My name is Jim Gooden and I'm Vice Chairperson of the Mental Health Foundation Australia. Mental health support groups can be a lifeline to people who are struggling. The Mental Health Foundation Australia provides support groups to benefit consumers, carers and other people who are struggling with mental illness. Our groups provide a safe and supportive environment for people to share their experiences and feelings. They are led by facilitators with lived experience who provide guidance and support. We offer a variety of support groups, including for people who are dealing with anxiety, depression, bipolar disorder and other mental health issues. Our support groups are a great way to connect with others who are going through similar experiences. They offer a sense of community and belonging that can be hard to find when you're dealing with mental illness. If you are someone who suffers, or if you know someone who is struggling with mental health issues, we encourage you to seek out our support groups. Visit our website today at supportgroup.mhfa.org.au. I would like to take this moment to thank the MHFA Board Directors and patrons, Scientific Advisory Committee and IT Advisory members, wonderful staff, community and media partners, multicultural ambassadors and attaches, youth leaders, MHFA members and volunteers, and major sponsors, Chemist's Own, Perpetual, Morris Blackburn and Foot Solutions for their continuous support of this organisation. We continue to work to deepen understanding of the importance of mental health and educating the community. Let's work in solidarity for the benefit of our mental health. We look forward to celebrating National Multicultural Mental Health Month this October. Thank you, Australia.
Now I would like to introduce our keynote speaker, Dr. Chidambaram Prakash and Sara Tatlow from the Royal Children's Hospital. Dr. Prakash is a senior consultant child and adolescent psychiatrist with 19 years experience. He has worked and managed general and specialist clinics within the child psychiatry. He brings to his work considerable and evidence-based knowledge in pharmacology, in psychopharmacology, and psychological therapies. Our next speaker, Sara Tatlow, is a clinical psychologist who has worked in the public and private mental health sector. Her experience include working in the child and adolescent mental health services and intensive mobile youth outreach service teams within the Royal Children's Hospital. Currently, Sara is the program coordinator of the Royal Children's Hospital's Hospital Outreach Post-Suicide Engagement Program. Please join me in welcoming Dr. Prakash and Sara Tatlow.
Hello, welcome. This is a presentation regarding child and youth mental health with my esteemed colleague, Dr. Chidambaram Prakash, and myself, who both work at the Royal Children's Hospital Mental Health Department, collaboratively within the Hospital Outreach Post-Suicidal Engagement Program, or the HOPE program.
Hello, everyone.
So when we're talking about youth mental health, we're referring to a state of well-being. So we're thinking about mental health in terms of how a child or a young person copes with their everyday life stresses. How are they productive at school and at home? How are they contributing to their community and their friendships? And mental health really determines how one manages that stress and those relationships with their friends and their family members. When we're referring to child and adolescent mental health, we're generally looking at people aged between 4 and 25 years, which is a huge age range, covering a number of developmental milestones and so forth. But we know the research tells us that over 75% of mental health difficulties do begin within those ages, usually before the age of 25 years. So early intervention, identification, and assessment is very important. When we're thinking about what can make somebody more vulnerable to developing mental health difficulties, for young people, children and adolescents, it can be a range of factors, as we listed here. There is increasingly more research suggesting that being a victim of bullying in particular is a big risk factor to developing mental health problems later in life, and certainly at the time. We know that there is an enormous amount of stress on children and young people at the moment around studying at school, particularly around exams for those in year 11 and 12. There is more and more research and certainly more young people coming through mental health services with gender and identity issues, or family breakdown, family violence, family relationship difficulties. There are just being a victim of discrimination or having physical health problems. So we're seeing more and more young people with significant health problems like diabetes, asthma, etc., coming through. And certainly, as many of us would know, having a lot of young people coming through with esteem and body image issues or concerns. And unsurprisingly, experiencing a big loss or change in their lives. So losing a grandparent or parent or loved one, changing of home or school can make somebody a bit more vulnerable to developing mental health difficulties at that time. When we think about multicultural factors, and this is by no means an exhaustive list, but there is a lot of research around how there are specific multicultural factors that impact on not only the development of mental health difficulties, but the actual help seeking or identification of those difficulties. And for some young people, children and young people, they talk about perhaps not feeling safe, or there being a culture within their family that is not conducive to speaking about having mental health difficulties, or indeed seeking help for those. In some families, there can be experiences of shame or confusion around what is mental health and when is it appropriate to seek help for those, and how it might be perceived by others within the community should their child or adolescent be seeking mental health support and indeed receive a diagnosis. And so, unsurprisingly, this can lead to people presenting to mental health departments a lot later in their mental health journey because they weren't identified earlier. We know that some people that are immigrating to Australia or having different experiences and part of their transition into schooling, that there can be some bullying and exclusion around cultural identity, there may be discrimination, and they may indeed have experienced some trauma in their experience of coming here and trying to settle in the Australian community. And all of these factors obviously contribute to the development of mental health problems for children. So how can these present? Some of these, and again, not an exhaustive list, but some of the ways that this can present in children and adolescents at home. Parents and carers might see their young person suddenly having problems sleeping. They want to sleep all the time. They're always tired. They're napping after school. Or the opposite, they're finding it really hard to get to sleep at night or to stay asleep. And they're wandering around the house at night time when they should be sleeping. A lot of irritability and agitation. They seem frustrated. Parents report feeling like they're walking on eggshells around the young person. There can be tearfulness and withdrawing to their room, not wanting to spend time with the family, appearing low or sad. And we often see a change in hygiene, so not wanting to shower, not wanting to change their bed sheets, wearing the same clothes day in and day out, their room becoming more and more messy. And unfortunately for some young people, it can also mean that they start engaging in self-harm, and we'll talk a bit more about that a bit later in the presentation. At school, it can look a little bit different. So we can see that they might be a victim and in some cases also the perpetrator of bullying towards their peers. They may start avoiding or refusing to attend school. It gets increasingly difficult to get them up in the morning, get them motivated to attend. And consequently, there can be a drop in grades or a refusal to complete homework, not wanting to do any work when they get home. There can be that friendship breakdowns, altercations, difficult with concentration and attention. And the teacher may start raising some of these concerns with the parents and carers at the parent-teacher interviews. In some cases, these behaviours can lead to suspensions, detentions, and leaving the school grounds. So a few concerning behaviours. Before we go any further, I just wanted to give a content warning. Part of this presentation is discussing suicide and self-harm, which in itself is a very distressing topic, but certainly even more so with children and adolescents. So some people may find part of this content distressing or confronting, and I encourage you to speak to somebody if you do so. If you wish to turn off, now would be the time. So what do we mean by self-harm? So it means somebody who deliberately hurts or injures themselves. And this could include a variety of ways in which that's done. And again, this is not an exhaustive list, but for the main presentations that we tend to see in children and adolescents if they're engaging in self-harm. So a really common self-harm technique is that of cutting. So this can be, they might take the blades out of the sharpener, they might use glass, break a glass and use the glass, they might use knives from the kitchen or the razor from their shavers, their razing blades. And sometimes they may hide this in their room or on their person or in their bags. And cutting is usually more often than not on the arms or on the thighs or legs. Some young people will engage in burning, so they might use a cigarette lighter or more commonly the candle lighters that you can purchase. Scratching is another common one, so they might use their nails and cut their nails so they're a bit sharper, or they might use pins that are used, for the for the pin boards and so forth, to scratch into their skin. And in some people, especially younger people, we might see hitting, so deliberately hitting their head against a wall or wanting to hit themselves and sometimes that's out of frustration. So we'll talk more about that in a moment. But it's important to note that a lot of people, and particularly young people, engage in self-harm to help regulate themselves with no intention of actually ending their life. It's a way of regulating themselves. And so what we get asked quite a bit from parents and carers is, why would my child or my young person want to engage in this and self-harm? Why would they want to hurt themselves? And so what some of the research has shown is that there is a myriad of reasons why a child or a young person might decide to engage in self-harm. These are some of the reasons here. And again, it can be difficult to think of a child or a young person feeling that they need to do these behaviours to help regulate themselves. But for some, they find it's a sense of control. It's one thing that they can control when it happens, where it happens, and how it happens, when they feel that the rest of their life might feel very much out of their control. For some, they feel they want to punish themselves because they haven't met expectations, or they've hurt somebody and they want to punish themselves through self-harm. For some, it's a way of showing that they're struggling. They might need more support, or they're having difficulty managing their emotions and they need support from the adults around them. For some, it's a sense of relief, and there are biochemical reactions that happen when engaging in self-harm that can feel like a sense of relief or calmness. And for others, it can be a way of avoiding, distracting, or escaping from their really big feelings and their emotions. How often does this happen? Apologies for the formatting here. So if we're looking back to 2021, some of the statistics from the Bureau of Statistics showed that it's more common in those that are 15 and over for young people in terms of hospitalizations for intentional self-harm. So this is people that have had to go into hospital for medical support around their self-harm. We're looking at 352 for every 100,000 young people. It's a much lower for those aged 14 and below, but it does still happen. In terms of completed death or suicide, again, much, much higher for those in the 15 to 17 age bracket, as opposed to those in the younger 14 below. And we know so far in the research that completed suicides or death by suicide is very rare in children, but unfortunately it does happen. So all of this suggests that early intervention is really, really important for child and adolescent mental health. So what can be done? What could be helpful? I'll hand over to Dr. Prakash to talk a bit more about that.
Thank you, Sarah. There are known to be interventions that research has shown, and our own clinical practice and experience of many colleagues, both in Australia and overseas, who have tried these interventions and have found them to be helpful. One of the factors that have been associated with problems with managing distress and stress later on in life, resulting in suicidal feelings, is having strong feelings in early childhood and problems with regulating the feelings, resulting in dysregulated behavior. Similarly, reducing exposure to environmental risks such as bullying and victimization is known to be quite helpful. So having rules in the schools and having interventions such as teachers and others sort of monitoring closely the interactions between young people and promoting positive social interactions is known to be quite helpful. Improving the emotional communication between children and their parents is quite important. Children do not come with their own sort of book on how to parent them. Parents do the best they can with the resources that they have. And therefore, sometimes there can be a problem in the emotional fit between the child and the parent, in that the child's needs and the parent's resources, the time they may have, the other stressors that parents have to deal with at the time in their lives, all may play a part in affecting emotional communication. So trying to improve that emotional communication through what we call as dyadic work, where there's work done with the child, work done with the parents, and then we bring the parent and child together to sort of do some therapeutic interventions, and mainly teach them different ways of emotional communication, improving emotional communication. Supporting parents and carers in seeking help for their own mental health difficulties is quite important, because the stronger they feel within themselves and more resourced they are, they're more able to be there for their children. Supporting an education of parents around healthy parenting parenting styles, reducing parenting styles that may inadvertently reinforce unhealthy sort of practices in their children, and also reducing exposure to adversity in the family as much as that is possible. More recently, there has been some interest in use of pet animals in therapeutic interventions, and also farm animals in therapeutic interventions. So the use of horses in what is called equine therapy, as well as dogs, cats, and other animals, has gained in importance and interest, and in fact has been found to be effective in helping children and young people, that is adolescents, engage with their therapists and learn different ways of self-regulation through the presence of having the pet animal in the therapy. And aside from that, and all these therapies may be provided with an animal in the room, but there are some therapeutic interventions that have been known to be useful and effective and have been studied quite rigorously around the world. And they approach the problem from different perspectives, because we are all different and different approaches might suit us. So, for example, for some people, the problem appears to be that they have a primary issue with dealing with distressed feelings or unhappiness or frustration, and we are unable then to regulate ourselves and the strong feelings that come. So for them, the technique called dialectical behavior therapy, where the child or the young person may have individual sessions and they are taught arousal regulation, they are taught to manage those feelings of self-harm or suicidality or impulsive behaviors. That's a therapeutic approach. Similarly, there is an approach called cognitive behavior therapy that focuses so much more on patterns of thinking and belief systems and how they might influence the behavior of the child. So there's a focus on management of thinking styles known as cognitions, and then to practice behavioral skills that help to modify the way people deal with stress and distressed feelings on a day-to-day basis. So again, the child or the young person will have individual sessions. In both the dialectical behavior therapy and the cognitive behavior therapy, we will involve parents in the sessions in order to learn the techniques that we have taught the child or the young person, so that they can continue to practice those sessions at home or those skills at home. Similarly, sometimes, having a psychiatrist or a pediatrician see the young person to find out if there are, target symptoms such as depression or anxiety or other symptoms that require the prescribing of medication, and also for the presence of an underlying neurodevelopmental disorder such as autism spectrum disorder or ADHD might be essential. And that might actually then lead on to other specialist referrals, like a referral to an occupational therapist or a speech pathologist or a clinical psychologist or a neuropsychologist for further assessments as well. There are a range of different neurodevelopmental disorders that might be seen in young people who have difficulties managing distressed feelings. As I mentioned before, there's now an increasing body of work and research into the involvement of various types of animals in the therapeutic sessions with young children as well as with young people. And they have most certainly been found to be helpful in the area of engaging young people in therapies, bringing young people into the therapeutic room, because it's not so much about sitting across the table and speaking to someone, which a lot of children and young people find difficult. But having the animal in the room helps to sort of kind of break the ice, help with the engagement, but also through the involvement of the animal, children and young people can learn arousal regulation and self-regulation. Similarly, there are therapeutic interventions that involve the family or the parents and the children, which is called the dyadic intervention, where the therapies that I mentioned already, the dialectical behavior therapy and cognitive behavior therapy, can be taught. Skills can be learned in the therapy room, which can then be practiced at home, whether they are social skills or communication skills between the parent and the child, emotional coaching skills for the parents, all of which are meant to promote a healthy parent-child relationship and healthy parenting styles. I'll hand back to Sarah.
That's right. So it's also important to think about what outside of the therapeutic space can be done to help strengthen a young person's mental health. And a lot of these may seem fairly obvious, but actually can be quite tricky for the young person to engage in without support from their parents and carers or teachers, etc. And it's really looking at the connection with others. That sense of belonging is really important, especially in the adolescent years and beyond. We're looking at eating well, sleeping well, engaging in hobbies or meaningful activities, having a sense of achievement around those, setting goals and excuse me, and how do we work towards those, having those where possible healthy and supportive relationships, again about connection with family and friends. And through these and the work done in therapy and so forth is building those effective coping strategies, or the therapeutic toolbox as we refer to it. So there is a lot of work that we've done outside of therapy that's very, very important. So when we're thinking about help, what help is available at the moment? So again, thinking about what the young person can do, there are some techniques that they'll be taught both in therapy. Some even learn this at school around grounding themselves, breathing techniques, the importance and the mode in which they communicate need for help. How do they reach out at school? How do they do that online or with parents or friends? How do they scheduling if they have to, spending time with others, engaging in hobbies. And there's a technique called urge surfing, which is often taught as part of DBT techniques around how do we manage or surf the urge to want to self-harm or worse until that urge comes down and we're able to cope a bit better. Learning about what their sticking points are, what are the situations where they most commonly experience negative or self-depreciating or even self-harm ideations. How do they come about? What can I do to either avoid them or plan around those? Again, around self-care and exercise, like the previous slide suggested, and really prioritizing sleep and sleep hygiene, because as we mentioned earlier, sleep, exercise, and self-care are some of the three things that we will see a change in the young person very quickly if their mental health is deteriorating. What can others do to support them? So, first is looking out for the signs that the child or young person might be struggling and reaching out to them. So not necessarily waiting for them to come to you, but reaching out to them, noticing that things have changed with them. Acknowledge them when they seek help from you. So even if you are busy and you're not able to have a lengthy conversation with them at the time they reach out to you, acknowledging that they have done so, plan a time when you will be speaking with them, and encouraging that communication is really important. Creating a plan, and again, this could be done with teachers, it could be done with therapists, it could be done at home, around what do we do, what works and what doesn't work when we are feeling down or angry or sad. Your GP is a really great source of referrals and information around mental health support. And often they'll be aware of the medical side of things for the young person too. So they can be a really good source of information. The school is another great source. So a lot of schools, hopefully most now, have access to school counsellors or psychologists or SSOs. And they might also have programs or wellbeing centre or room, fidget toys, etc., that can help a young person regulate themselves in the school environment. So really important that the school are aware if you're having concerns about the child or young person's mental health. And I think there's an acknowledgement that sometimes they may not wish to talk about what's happening, but they might want to be near you. So they're having a difficult time. They may not have processed or realized why or what's happening, but they want to be near someone while they're working that out. So it's okay for them to be near, and inviting them to talk when they're ready is really important. So not forcing them, but inviting them. As I mentioned, where else can we go for support? So school counsellor wellbeing, really great resource at the school, your doctor or GP. There's obviously private practitioners that you can access through referral from your GP. So psychology, social work, mental health, nursing, paediatricians, etc. For some people, they may also look into support from their religious centres, so whether it's a church or mosque or what have you, that may have counsellors available there that are trained in mental health first aid or able to talk with you and help navigate the process of seeking support for your child or young person. There are a myriad of helplines, again, not an exhaustive list. Many people have heard of Kids Helpline, Beyond Blue, Headspace, all of which have online support, counselling support, and Headspace indeed have centres where you can seek counselling support for 12-year-olds and up. So you can Google them and find out who's closest to you. There are a lot of online forums. So again, a lot of young people don't want to talk face-to-face. They want to chat or they want to text. So Beyond Blue and Reach Out, for example, have online forums where they can liaise with other young people or counsellors online. So trying to make that access easier. There are support centres. So again, Headspace. An example for those living in the Wyndham region, the Wyndham Youth Resource Centre. There are resource centres through most councils, so you can search that through your local council. If you're within the Western Metropolitan region of Melbourne, then our service, the RCH Mental Health Service, this is the number, offers support for young people aged 0 to 15, excuse me, until November. And then we were going to 0 to 11 from then. And then the next service up is Origin Youth Mental Health. And that's their number, And again, they're for 15 and older at the moment, and they'll be 12 and older in November. There are also online programs and apps. So Bite Back, a Brave program, the Mood Gym, most of these are free. They're online. They provide support around well-being and resilience. And a lot of young people prefer to engage in the online platforms as a way of seeking support. Then what about the parents and carers? So there is hope out there. There is help. Some of you may be familiar with Parent Line. So they have a website, but also a phone number if you're wanting counselling and parenting support and advocacy. A really great resource is the Raising Children's Network, which has a myriad of resources around common child and adolescent mental health and physical health difficulties, where to get support, what to look out for. Carers Victoria provides support and information to parents and carers looking after a young person with mental health difficulties. And another example is Anglicare. They have, if you go on their website, they have more programs uploaded all the time, but one example is Parent Zone, where they provide counselling and parenting support. So that's all from us. We really appreciate your time, and hope that you got something helpful, useful, and practical from today's presentation. Thank you.
Thank you.
Thank you, Dr. Prakash and Sara, for your excellent presentations. It is my great pleasure to introduce our next keynote speaker, Dr. Alberto Veloso. Dr. Veloso is a specialist child and family psychiatrist and general pediatrician. He is passionate about child and family mental health with a particular focus on understanding and assisting the emotional development of children and adolescents. His clinical focus is assessing and treating mental health problems by integrating our understanding about brain development, the impact of relationships on emotional maturity, and evidence-based biological and psychological treatments. Please join me in welcoming Dr. Alberto Veloso.
Good morning, everyone. Again, it is a pleasure to be a part of National Mental Health Month for the Mental Health Foundation of Australia. My name's Alberto Veloso. I'm a child psychiatrist and a general pediatrician, and I've been a proud supporter of the Mental Health Foundation of Australia. And today we are really excited because we're talking about my favourite topic, which is child and adolescent mental health. So we'll get right to it. So I'm firstly going to acknowledge the traditional owners of the land on which I stand, the Dja Wurrung, here in the Western Ranges. I'd like to acknowledge all Indigenous people and all elders, past, present, and emerging. Secondly, I'd also like to acknowledge those with lived experience of mental illness and those who struggle with their mental health. Today, I'm talking a lot about parents, and they are such an important group of people for our children and our society, and also to acknowledge and thank the Mental Health Foundation of Australia for this opportunity to present to you. Our community is a very multicultural population, and I myself, who immigrated from the Philippines as a child before becoming a psychiatrist, I'm grateful for all the opportunities I have and what the Mental Health Foundation of Australia are doing to promote multiculturalism and also mental health. I'm really proud of, and it is a real privilege for me to be part of the Scientific Advisory Committee for the Mental Health Foundation and today, which brings me here today. So my roles is mostly as child psychiatrist these days, and what I do is I head a private child and adolescent mental health clinic where our focus is really about supporting parents to support their kids. We have a team of clinicians, and we're trying to build this workforce of clinicians who can support parents and teach parents that they can be therapeutic in all of their interactions with their children, which can make a world of difference for the treatments that their children receive. So because the proportion of children who suffer from mental illness is great. These are recent surveys to say that that we've got quite a large chunk of these. This is data for children under 12 years of age, and thankfully they haven't been too drastic in their increase in time. But 10% of children in this survey, the Victorian Child and Health and Wellbeing Survey in 2021, is quite a decent number of kids who are struggling with emotional development or behavioural problems. The other thing to highlight in this is that there is a distinct imbalance between metropolitan and rural areas, and then there seems to be quite a big imbalance between single parent families versus families that have more than one parent, and then a huge disparity between those who have a higher or lower socioeconomic status. So we could spend a long time talking about these numbers, but I think that the point is quite salient that there's a lot of work we can do to help children who have mental health and behavioural or developmental issues in our community. There is another worrying trend, which is that as kids get older, they tend to have more problems. This is a student health and wellbeing survey in 2018. So, there's lots of questions raised about pressure at school and the school environment and what we can do to help kids with their mental health and wellbeing. And females tend to be more at risk or seem to be having more trouble coping with their environments. So lots for us to advocate for, lots for us to think about. Now, more to the topic of this talk is the fact that we've got parents who, 5% of parents with children aged under 12 years of age that report very high levels of psychological distress. And again, similar spreads in terms of rural metropolitan in this case wasn't too far away, but the socioeconomic status seems to be a big difference. And again, those in single parent families. And in the Parenting Research Centre survey, they talked about that, that there's actually quite a reasonable proportion of parents who experience psychological distress. And a lot of parents seem to report that they actually have a lot of trouble finding time or ways to look after themselves. So, this kind of sets out the scene that there are definitely difficulties that our parent-child system has in terms of how do they support young people or their young people who are struggling with their emotions. Now, what does this mean? The risk, of course, is that the parents who have poorer mental health or struggling with their own mental health are more likely to use harsher discipline. Parents less likely to use positive parenting strategies. They yell or argue more with their children, and parents with poor mental health report high rates of wishing that they never had kids, but also that that they wish that they were more patient with their children. So. And there's a bit more evidence. So there's quite a bit of qualitative data throughout the world that talks about the impact of parental mental illness or parental struggle on the health of children. So I think it really highlights for us that we really do need to be careful about where we target things. And this is, of course, one of the things that we work on at Relational Minds, is that one of the reasons we exist is because of the fact that we can't just keep sending kids to individual therapy. we have to somehow advocate for and take a focus on helping parents who are struggling. So today, what I wanted to do is, talk a little bit about why it's important for parents to have support, why it's important, what parents can do to recognize when things are a bit difficult for them. So, because with the right support, it's not always a negative outcome, right? There are lots of parents who do well. And often what I talk about with parents is that sometimes it's about the fit between the parent's parenting style and their child's way of learning or their child's way of seeing the world. And what's important is that there is a goodness of fit between the two of those. So it's actually really important that parents think about themselves, think about how they care for themselves, and that really to accept that you can't just keep powering on. You can't just keep I'm just going to keep going because that's what I know how to do, and that's what society tells me how to do. We have to take care of ourselves, because otherwise strange things happen. And this image I chose because one of the common issues that come up is that the child starts to care for their parent. And if that happens to children, particularly children of young age, that can cause some issues in their development because they can't develop in a natural progression or natural state, because they then have to have this burden of responsibility or perceived burden of responsibility towards their parent. So what I wanted, in the brief time that we have today, what I wanted to do was highlight some of the ways that parents can recognize that maybe they're not doing so well, or recognize the need to do more self-care. And I wanted to do that by talking about the parenting brain systems. There are biological brain systems that are designed and geared to help parents care for their kids, and geared biologically so that the parent-child system succeeds and the child is safe and our whole species continues. Right? So I'm going to go through a few of those and use those examples as ways to help parents recognize that maybe I need more support than I think I do, or I need to do more to support myself. Now, the first of those caring brain systems is what's called the approach system. So, and that relates to a hormone called oxytocin. Oxytocin is released in a parent's brain that helps them want to be near their child. And this is one of the things that's actually a very powerful hormone that's released soon after birth. So parent and child both want to be close to each other. The parent's open, engaged, and wants to be with their child. But when things are difficult, or when parents are stressed, or other life stress, or even more difficult, and I think a lot of parents can relate to this, that sometimes their child's difficulties cause so much stress in the family and the parent that you actually stop wanting to be near them, right? Odd. It's an odd thing, and you kind of, as a parent, you don't feel great about that, because we want to be near our kids, but for some reason, the situation that we're in somehow leads us to not wanting to be with them, and that's related to oxytocin. That that there are actually biological systems that try and protect your parent brain to want to avoid your child instead of the drive to want to approach your child. Okay, so these brain systems I really want to highlight these, that there are brain systems that happen in you as a parent that you can't help. These aren't choices that you make. There are things that can happen as a result of lots of stress, particularly if it relates to your relationship with your child, that can actually kick in and try and protect you as a parent. And one of these is that this oxytocin system will shut down, and you won't want to be near your child for your own safety. The second system is the reward system, which is related to dopamine. Right? So we've all heard about dopamine, the pleasure hormone, or pleasure neurotransmitter. It's not a hormone; it's a neurotransmitter. It's released when we feel relational joy. It's released when we feel that things are pleasurable, and this happens in our relationship with our child. That we get this hit of dopamine when we feel pleasure with our child. But sometimes that can also shut down. Because if you're too stressed, or if you're not, your own mental health is suffering, or your relationship isn't going so well, you will find that I don't seem to feel enjoyment in my relationship with my child anymore. Now, sometimes part of it is because your child's going through some stuff and it's not enjoyable parenting them. But if you're not careful, sometimes over time that can become, you just actually don't feel it, even if your child is better, or if your child is doing more positive things, you still might not feel that enjoyment, and it's no longer about your child. That's more about your brain protecting yourself. Yeah. The next brain system that I want you to think about and be aware of is what we call the child reading system. So parents are naturally curious about their kids. Oh, I wonder what he's thinking. I want to make sense of, I wonder what he's looking at. I wonder how he sees the world, or he or she. Well, we're attuned. We go, oh, they're a bit curious, or they're a bit edgy, or they're really happy today. We're open, we accept, and we engage, and we take them for whatever they come with, right? And so we see them as just this. We look at our children from outside and we go, wow, we wonder how they experience the world. But sometimes if we're not careful, or if a situation's not great, or a relationship's not great, we can become defensive and protective, right? We can start to stop wondering about our child, and we start to judge. Oh, they must be going through this. And we start to have a negative bias about what they think. Oh, you're just manipulating me. It's something we really need to be careful of. And another one that's related to that is what we call the meaning-making system. So our brain works by creating stories. Right? We create a narrative, we create stories to explain our experience. And usually we try, we have a fairly balanced narrative, right? And even, we even err towards the side of positivity. We convince ourselves that our children are the best in the world. Oh, they're so much more advanced than the other kids, right? And we make our meanings like that. But there are things that also affect the way that our brain makes meanings, and sometimes that might be because of our past relationships, or past histories, or our experiences with our child. And sometimes, if we're really stressed, or if our parent-child relationship causes us stress, we can be more likely to hold negative meaning, like define our child as bad, naughty, or manipulative. Or we might think of ourselves as a failure, so this narrative, or the meanings that we make, you will find will start to err towards the negative, right? Instead of being more balanced, or actually, what's meant to happen is we're meant to become a bit more positive, or even, overly positive. Sometimes, unreasonably so, or unfoundedly so. So be wary of that. And the last system is what we call the executive system. Well, we know that the executive brain system, there's this explosion of knowledge and understanding and acceptance of ADHD right now. So we have that's what we call that ADHD: attention, focus, planning, strategy, impulse control are all part of what we call our executive brain system. And it coordinates function of all other parts of our brain. So sometimes what we then notice is that if we have too much stress, we find that those functions fail. And you go, hang on a sec, this is not normal for me. I'm normally more able to plan, to strategize, to remember things, to not lose my focus. And so if I'm not doing that, and because of course, what do our children need, right? Our children, especially at a younger age, haven't developed these systems themselves. So what do they need? They need us. Well, they need us to help them, to lend them our brains, to develop those systems. So super important. So these are probably, these are some brain systems that I wanted to highlight today, to help our audience, to help parents, to think about these systems. So let's go through them again. So the approach system: if you find yourself not wanting to be with your child, if you find yourself not experiencing pleasure or joy in the presence of your child or in your relationship with your child, when you start to look at your child with judgment instead of being open and wondering, okay? And fourthly, having leaning towards negative meanings or negative stories, narratives, and conclusions about your child or your relationship. And then your executive system, you're forgetting things. You're not as organized as you used to be. And so if you really find that you start to notice one or more of these systems that are starting to fail or starting to slow down, you go, oh, I'm really starting to notice this. That should be a red flag. And that's a clue that you need to look after your brain more, because you need to recover those systems, right? And, you know, this isn't a talk about self-care, but there's lots, there'll be lots, and, you know, hopefully some topics today, you'll hear about how a parent or a carer might do self-care, but we can talk about that a bit more at another time. So it's really, really important to highlight this, and it's really important to care for yourself. Again, my great pleasure to be part of National Mental Health Month and the Mental Health Foundation of Australia, and thank you so much for allowing me to present today, and for your attention.
Thank you very much, Dr. Alberto Veloso, for your excellent presentation. Now I would like to invite our next keynote speakers, Anna Smout and Tiahna Martin-Parker from the Royal Children's Hospital. Please join me in welcoming Anna and Tiahna.
Hi everyone, my name is Anna. I'm a PhD candidate with the Monash Turner Institute and a project officer with the Royal Children's Hospital. Thanks very much for listening today. Before I begin, I'd like to acknowledge the traditional custodians of country throughout Australia. I'm currently on the unceded lands of the Wurundjeri people of the Kulin Nation. I'd like to pay my respect to their elders past, present and emerging, and extend that respect to any Aboriginal and Torres Strait Islander peoples listening today. Today, it's my pleasure to introduce Partners in Parenting Education, or PIP-ED, an online program designed to empower parents to respond to school refusal, anxiety and depression in their teenager or adolescent. I'd like to thank the key supervisors, collaborators listed below. I'd like to acknowledge their input and guidance into this project. Before I introduce the program, I'll start by providing a bit of background about why we developed it and how. So first, what do we mean by school refusal? So a young person is experiencing school refusal if they have difficulties attending or remaining at school during the day due to emotional distress about attending. School refusal can be incredibly debilitating for the young person and for those caring for them. It's usually driven by a young person's attempt to manage with overwhelming difficulties related to school attendance rather than naughtiness or defiance. And so for this reason, young people experiencing school refusal often remain home with their parents' or caregivers' knowledge, henceforth they'll use the term parents, and despite their parents' best efforts to get them along to school. Often they really want to get to school themselves and don't know why they find it so hard. They might feel embarrassed or ashamed that they struggle to get along to school. And so for these reasons, although it's widely used, we acknowledge that the term school refusal is not always accepted as the best or the most relatable term to describe the behaviour. So it's often also described as school can't or school avoidance. For the purpose of this presentation, I'll be using the term school refusal. It's also important to acknowledge that many things can contribute to anxiety about school and make school a really hard place to be for a young person. There's no one single cause of school refusal. In reality, it's usually a combination of many individual, school and family risk factors like co-occurring mental health issues like anxiety or depression, which is common, medical issues, learning and attention difficulties, bullying, the list goes on. School refusal is not only hard for the young person, it's also incredibly hard for their parents and caregivers. We know that parents of young people who refuse school might feel distressed and exhausted and lack confidence about how to support their child. In large part, this is due to a general lack of awareness about the issue, that it has a name, that other young people and families go through this, where to find information and support, and what to do about it. Just like there's no single cause of school refusal, there's no single or prescribed way to resolve it, but there are things that parents can do to help. And this is why PIP Ed, Partners in Parenting Education, was developed. So although many individual, school and family factors can interact to contribute to school refusal, the empowerment of parents or any adult in a caregiving role is especially promising for a few reasons. The first being that many young people don't receive professional support either because it's not available or they might not want to. And in many cases, this means that parents often can't receive guidance about how to support them either. Second, evidence tells us that parent-focused treatments can and do improve school attendance. Many of the evidence-based risk and protective factors for anxiety, depression, and school refusal are within parents' influence. Parents are often motivated to support their child's school engagement and mental health, and are a really important link between the family and education provider. But foremost, parents who participated in some of our previous trials run by our team told us that they really needed this support. In response to these needs and gaps, we developed PIP Ed. So what is it? It's an online program that's designed to empower parents and caregivers to support an adolescent who's refusing school in the context of anxiety or depression. The program is completely free and self-guided, meaning you can complete it whenever and wherever you like. It is the newest Partners in Parenting program. So Partners in Parenting translates decades of research evidence related to the prevention and early intervention of adolescent depression and anxiety disorders into practical and accessible resources for parents, which is accessible at our website, Partners in Parenting. And also, it's also really important to note that the program and the module topics were co-designed with input from parents, education sector staff, and young people who either had lived or professional experience of the issue. The content is based on very high quality research evidence and international expert consensus, all of which is summarized in our freely available guidelines. I've put the link and the QR code to these guidelines here in case it's of interest. The PIP Ed program contains all of this content and expands on it further, but these guidelines are here for you if they're more relevant to you in the context of prevention and early intervention. So yeah, QR code there, or accessible at www.parentingstrategies.net. So back to PIP Ed, how does it work? First, you complete a survey about your parenting and your parenting confidence. And then based on your responses, you're provided some tailored feedback and recommended a series of modules, online modules to complete. So these online modules cover different topics related to parenting. You can complete anywhere up to 13 modules. It's recommended that you complete one module per week, but you can complete them as quickly or as slowly as you like. At the end of each module, you select a goal to work towards related to the topic. And once you've had a chance to put your learning into practice, you can start your next topic until you've completed all that are of interest to you. You'll also be asked to complete a survey at the beginning and an optional survey when you finish the program. So the module topics are listed here. I won't read these out, though I'll just note that the two modules here are specific to school refusal, the remainder being broadly relevant to parenting an adolescent who's struggling with anxiety or depression. So importantly, how do you access the program? As I mentioned, the program is completely free and anyone can sign up. I invite you to follow this QR code here. It'll take you straight to our landing page, pip-ed.web.app. The program is being offered as part of a research trial right now. So that's why there's a survey, and we'd so appreciate if you did the follow-up survey at the end. That will help us progress this work. Although anyone can sign up, it is intended or designed specifically for the needs of parents and caregivers of teens aged 12 to 18 who are refusing school due to anxiety or depression, who are fluent in English, and who have internet access. Importantly, the program is not recommended as a sole source of support for young people experiencing school refusal. We do recommend seeking professional support from a mental health or education professional alongside completing the program. And again, although all parents can take part, just to note that the program content is not specifically tailored to the needs of parents of teens who are living with autism spectrum disorder or intellectual disability. And what if, for some of you, your child is struggling with their mental health but not refusing school? Fortunately, we've just launched Partners in Parenting Headspace. So Partners in Parenting Partners in Parenting can now be accessed for free through Headspace as part of a new collaboration between Monash University and Headspace National. So for those who aren't aware, Headspace is the National Youth Mental Health Foundation that provides early intervention mental health services to 12 to 25-year-olds Australia-wide and their parents. So parents and professionals can now access Partners in Parenting via a Headspace online account. So it's very quick and completely free to set up an account. You can visit that page by this QR code or by searching Partners in Parenting Headspace in whatever search engine you use. It should be the first thing that comes up. PIP Headspace is designed to help parents and carers build skills and confidence in supporting their adolescents' mental health and well-being. It contains 10 online modules which cover common parenting challenges in this context, like communication, managing strong emotions, boundaries, and so forth. Essentially, it's just like PIP Ed. You complete it in exactly the same way. It just doesn't have the school refusal content. And as I mentioned, accessible at this QR code or by searching Headspace Partners in Parenting. Thank you so much for being here for this whirlwind tour of the programs that we currently have available. I hope that that they'll be of use to some of you listening and maybe find you at the right time. If you missed any of the links or QR codes or anything, have any questions about any of what I've just discussed, please feel free to contact us. We can be contacted at med-pip-ed@monash.edu. There's no AU at the end, or through the PIP Ed website at pip-ed.web.app/contact, or by scanning the QR code that you see just here. As I said, we welcome any and all questions. Thanks very much for listening.
Okay, so today we're going to be talking about the family care peer work in a child and youth mental health service. So who am I? My name's Tiahna. I'm a care and peer worker on the Child and Youth Hope team at the Royal Children's Hospital. I actually have a background of nursing in an acute care setting, including the wards and the emergency department. I also have lived experience of caring for a young person who's had their own struggles with mental health. So that means that I do have first-hand experience with some of the confusion, questions and fear that might come along with caring for a young person who requires the support of a mental health service. And I'm employed in this role to connect and support with families and carers of young people who have either had a suicide attempt, deliberate self-harm, suicidal ideation, or a mixture of those three things. Although today is only a very short presentation, and I'll try not to rush too much, but I want to get as much in as I can. It's only a small snippet into my role, but I hope that I can bring a little bit of clarity for some of you in understanding what lived experience is and what someone working in a carer lived experience role can bring to your service and to the families that you're supporting. So first, I just want to acknowledge some terms. There are lots of terms to describe my role. Some of them may be a care peer worker, a family peer support worker, a family peer specialist, a carer lived experience, or a family carer peer worker. But here at the Hope program, I use the term carer peer work, so I'll be referring to that term during the presentation today. So what's a carer peer worker in child and youth mental health? There's someone who works within the Child and Youth Mental Health Service, providing support to families and carers from a lived experience perspective. A carer peer worker is a non-clinical role, but it is a therapeutic role that sits within a clinical team. And carer peer workers have their own lived experience of caring for someone who has experienced their own mental health struggles. Carer peer workers work in all different services, and they're based everywhere, and some of the services that they're currently employed in might be an AOD service, older adult mental health, acute mental health, community mental health, lived experience advisory roles, policy and governance in the Department of Health, eating disorder services, workforce development, executive transformation teams, research, the list goes on. And KRP workers come with a wealth of knowledge and experience and from all different backgrounds. But today we'll be focusing on the care lived experience role in the child and youth mental health service. Probably wondering, what support can a KRP worker actually offer to families? There's lots of things, just being there for a chat for a family member, whether that's about something for themselves personally, whether that's about the young person they're caring for or experience they've had. We can help family members and carers seek in with different services, whether that's a referral for financial support, psychosocial support, psychological support, and we can support family and carers in their decisions and advocate for them in the treating team. We can attend other appointments as a support person, whether that be a psychiatric review, a family therapy session, whatever that looks like for your service. We can provide psychoeducation on topics from a lived experience perspective and provide strategies that have worked for us in the past or in the current life that we're living. And we can help families to navigate the mental health system. We can also walk alongside families and carers as they learn to deeper understand themselves and their own needs. We can teach family and carers self-care strategies and ways to implement them. We can answer any questions a family may have. And that's different for anyone and everyone. Whatever questions they throw at us, we'll always try and answer or get the answer to. We encourage families and carers to feel confident in situations, and we empower them to change when they feel ready. We're often the point of contact for families and carers within the service. We assist the treating team with better understanding the family and their needs, and that helps to improve the outcomes for the consumer and the family. We also run care support groups for family members of children accessing the service. So how do care review workers and clinicians work together? Well, we can provide support and communication between the clinical team and the family or carers. We can provide support and resources to the family or carers that may otherwise have to be done by the clinical team. We work as part of the care team. And this is something that the HOPE team does a lot, especially my team. We collaborate on cases and work together to best support the family and consumer. We share findings and views with each other to provide deeper understanding of the family and their needs. We provide advocacy and a lived experience perspective to cases and multidisciplinary meetings, including clinical reviews, care team meetings, peer reviews, referral discussions, the list goes on. We help to answer family and carer questions about the mental health systems and their processes, and we can assist with navigating this with them. We can assist clinicians to uncover barriers to a successful engagement and the discharge of their services. And we can work with families and carers to build confidence and capacity in caring for their young person. So these are some things that are specific that I do. They're specific to the Child and Youth HOPE program here at RCH. So I attend referral discussions and provide a lived experience perspective. I suggest things to be considered from a family or carer's perspective during those meetings. I contact carers to introduce the HOPE program and offer a meet and greet on an as-needed basis. I lead meet and greet sessions as per a rotating roster. I send out welcome to HOPE emails to every family and carer when they come on board with HOPE, and that will have brochures about accessing mental health, their privacy, outcomes. It's also got a brochure about my role so they can better learn who I am. I also attend initial assessment sessions as a support person for the family where I can. I collaborate with the HOPE clinicians daily on different cases, what might be happening for them and anything that needs to be considered or completed. I run monthly carer support groups for family members of children accessing HOPE. I liaise with the family and carers about their needs, and I chat to them about what we can do to ensure that those are being met. I'm quite often, I think with most families, the point of contact while they're accessing the HOPE program. I provide scheduled and ad hoc support to family or carers via phone call, text, email, telehealth, face-to-face, whatever that looks like for them. I attend all meetings, including clinical reviews, care team meetings, handovers, etc. I provide lots of resources, including PDFs, videos, books, articles, research articles, on all different topics at the request of the carer. I attend family therapy sessions as a support person for the family when I'm able and when it's appropriate. I provide access and complete applications for the Carer Support Fund. And I complete referrals to external services. So that might be places like Orange Door. Okay, so that's the end of our very brief explanation of what my role is like in this service, but I've put my contact details up here, so feel free to contact me at any point. If you've got any questions, you want to have a chat, I'm always open to a chat. That's my direct work mobile. I'm not sure if these slides will be sent around, but feel free to get in contact with the Mental Health Foundation if you need the contact details. Thanks, guys.
Thank you, Anna and Tiahna, for your excellent presentations. This brings us to the closing of today's Child and Adolescent Mental Health Forum. I would like to thank you all for joining us today. I also want to thank our presenters and speakers, Dr. Prakash, Dr. Veloso, Sara, Anna, and Tiahna, and our staff for their effort in putting this event together. We hope you have taken away some very important pieces of information. Thank you, and we look forward to your participation in future events during the month. Bye for now.